I'm Mike Guralnick. Dr. O'Connor couldn't attend, but this is his data. I don't have the disclosure slides, but neither of us have any relevant disclosures. We're both speakers for Astellas. So the standard injection technique for Botox is actually 10 to 30 evenly spaced trigone-sparing injections of anywhere from 100 to 300 units into the posterior lateral bladder walls. And if you look at the published results, which we've actually seen some of them, efficacy is anywhere from 35 to 65%, durability 12 to 39 weeks, and a UTI rate anywhere from 2 to 32%. My partner, Dr. O'Connor, has actually been injecting far fewer number of injections with the same amount of Botox and achieving fairly similar results, which we're going to present. So this was a retrospective chart review of his patients. These were Botox-naive patients with medical refractory, urodynamically confirmed neurogenic Detrusor overactivity or idiopathic overactivity that underwent Botox-A injections. We had patients fill out a questionnaire that includes the ICIQ urinary incontinence form. They were also asked subjectively what their perception of improvement was, and we used a greater than 50% improvement for outcomes. How many achieved complete continence? We then, on our questionnaires, also look at adverse events, including UTIs, muscle weakness, et cetera. And then we looked at durability in those patients who had an improvement, who then had enough follow-up to ask for repeat injections. So the procedures done under intravenous sedation or local. For neurogenic Detrusor overactivity, they were injected in 2 or 3 sites, anywhere from 160 to or 300 units, depending on their ability and desire to volitionally void. The patients who were catheterizing got 300 units. The idiopathic patients got 1 or 2 injections of 100 units if they were older than the age of 70 and 180 units if they were less than the age of 70. These are trigone-sparing injections with the Botox reconstituted as 100 units in 5 mLs of saline. Just looking at the demographics, the majority of patients here were female. The idiopathics were all voiding. About 60% of the neurogenics were doing catheterization. And the main reason for Botox was inadequate symptom control with medications. And with the results, looking at the total results, we see that the overall ICIQ improvement had a median improvement of 9 points, and then in neurogenics it was 13 points, idiopathic 6 points. And of those patients who achieved an at least 6-point improvement in their ICIQ, roughly 90% of neurogenics, 57% of idiopathics, and overall 73%. Subjective improvement greater than 50%, again in 70% overall, 86% in neurogenics, 57% in idiopathics, and the total dry weight was about 50% in neurogenics, 35% in idiopathics, and 42% overall. As far as adverse events go, mild hematuria occurred in 8% and it resolved in 48 hours. UTI occurred in 11%, and that should be on a separate line. There were no systemic Botox adverse events, and the mean post-injection, post-void residual in patients who were voiding pre-op was 92 milliliters. Durability in those who had follow-up was roughly 29 to 30 weeks. So compared to published results of the standard technique, it seems that a fewer number of larger volume injections has similar efficacy, durability, and complication rates. Obviously, this requires a prospective study, which we're trying to perform. This was sort of a pilot study just to present some results to get some interest. We're actually trying to get Allergan to actually sponsor a study. Thank you.
Thank you. Interesting. Interesting. We have the same experience with the same results. Very good study. Yep.
Saladin Lucy from Germany. Congratulations, these results are really awesome. We actually inject in 10 injection sites and video aerodynamically proved that it has the same efficacy that 20 and 30 injection sites, but with only 2 or 3 injection sites, if the success is as you have told us and as you have shown the data, I really have to appreciate this study. It's really great.
It definitely simplifies it.
You had neurogenic patients, so in those kind of patients you might be concerned about Detrusor overactivity pressure. Did you look at the results, urodynamic results?
Not in this group. In the patients that we're now following prospectively, we're looking at pre-op and post-op urodynamics. I don't have the results for this group.
And you have data on injection site pain. Is it larger because you have a larger tissue stretch or distortion?
It's a great question. To my knowledge, because I don't do it this way, I'm still doing it the old-fashioned way, and that's what our prospective studies kind of compare. I haven't heard that they're complaining because he's been doing it this way for several years now. I would think if it was too painful, they'd be stopping. Again, in a lot of the neurogenic patients, they're asensate, so it's not an issue.
It's not too painful, but it's more painful.
I believe that.
More questions? Thank you very much.